Thanks very much. It's a pleasure to be able to speak to you. It's late in the afternoon. That has two disadvantages. Well, I guess let's say two advantages. One is that the groundwork has been laid, so a lot of things don't have to be repeated. The second is that the herd is relatively docile, and one can maybe make inflammatory statements and get away with them. We'll see. I'm actually going to disappoint the chairman because I'm not going to be able to give you the definitions that you actually want. So we're going to talk about two things: the change in the patient population. We've heard a bit about that, and as well this concept of insufficient treatment response. And this came out from the topics that were forwarded to us by the EMA about the changing MS patient population and how that impacts on benefit risk assessment, as well as this concept of insufficient treatment response. Now, if we think about the changing MS patient population, there's changes in terms of the baseline characteristics as well as the on-study characteristics, and we'll look at both of these. And what I've done here is taking various studies from the beta seron, that's at the start of the interferon era, I guess, the rebif, the end of the interferon study era, then the Tysabri in around 2000, and then the orals from 2005 to 2010, so spanning about 20 years. Of therapy, keeping in mind the beta seron study had started even in the late 80s. A little bit contrary to what was said is that there's not a number of factors have actually not changed that much. If you look at the age, it's maybe drifted up a year or so. The proportion of women has maybe drifted slightly. Disease duration was sort of creeping up, but then has come back down, and so it's a bit variable over the time. The things that have changed there are highlighted in red, particularly the proportion of patients who have received prior therapy. And this has now gone from very low percentages, including in the Tysabri era, up to now a third to a half of the patients, and probably going forward will be even higher. The EDSS has actually not changed that much. There's possibly a slight drift downwards, but if you look there, probably the range and the overlap is rather substantial. But the disease activity coming in, as had been highlighted, has changed in that the 2-year relapse rate has previously in the 3 range has dropped to about 2. And we don't have data on the 1-year rates from the earlier studies. So pre-disease activity in relapses was slightly higher, although the EDSS was not substantially different. The real difference, of course, has been in the disease activity on study. And you see here again in the red, these are the control arms, placebo in all cases. And you see that it has, the relapse rate has drifted down by about 2/3. And then the proportion of patients who are relapsing has gone up by about 3-fold, so that now almost half of the control patients are no longer contributing signal in the clinical trials, which leads to obviously higher sample sizes. And there's part of the reason for the drop in the relapse rate is possibly in terms of definitions and requirement of confirmation of relapses, but clearly reflects the availability of therapy and the nature of patients who come into the clinical trials. So this graph here, this table here, just shows the various factors that one could think about in terms of the change over time and the potential impact that they have. And I've highlighted 3 of them there because these are the ones that probably are the most relevant in terms of the change over the last 2 decades, and particularly the issue related to the proportion of previously treated patients, which is substantially higher now. And the relevance there is that these patients are generally less responsive to therapy than the treatment-naive patients. So one has to always think about that when looking at the clinical trial data. And then, of course, the reduced relapse activity on study. We've seen a several-fold drop in the relapse rate or an increase in the proportion who are relapse-free. And what this leads to is a floor effect in which you start to get into very low numbers. And particularly if we're thinking about active controlled studies, how much movement one can see if you're already down in the 0.3, 0.4 range and 0.2 range for active therapies. Also leads to some difficulty in interpreting the effect size because now a very slight difference in the relapse rate can lead to a more magnified look in terms of the treatment effect relative to the control group. So I want to look at a few specific issues with patient populations, and this relates to the language within the guidance. And here, one was saying that, again, we've just had this discussion about compounds with modest efficacy should be used in patients with early disease and or a benign course. And I think there's been a lot said all day, but early disease does not equate to benign disease. Early diseases we've seen repeatedly as actually more responsive to the therapies than later in the course, mainly from the CIS experience. Every drug that's been looked at there is somewhat more effective than in the later relapsing group. Therefore, these patients should not a priori be relegated to potentially less effective therapies, be it either in clinical trials or post-marketing, as we've had an extensive discussion about. There's some comment about the CIS indication now being covered by the change in the McDonald criteria such that it virtually doesn't exist anymore. And I think we would tend to agree with that. That's not a contentious issue. One of the things we've heard a little bit about today, and we also heard recently at the keynote lecture and at the ECTRIMS meeting, is the radiologically isolated syndrome and a call for studies in that patient population group. So it's just possibly a word of heads up to the people who write the guidance that radiologic isolated syndrome should actually be considered potentially at a minimum discussions with the agency before such studies are done. The next group is this concept that the secondary progressive study in the language in the guidance at the moment indicates that products that are being looked at for disability progression in the SPMS patient population should only include those without relapses. And we would tend to disagree with this for a couple of reasons listed here. Firstly, the relapsing SPMS forms part of the spectrum of secondary progressive MS, and as we all know, it's very difficult to know where that transition occurs, and therefore getting a clear definition on who a non-relapsing patient is could be problematic. George would disagree, but certainly a proportion of the disability progression in MS relates to relapses, and I would just have to say I disagree with George, but that's okay. I have data. and you have seniority as well, George. So the one of the concerns that you have is that patients who are supposedly non-relapsing SPMS patients, when they go into the clinical trials, actually have relapses. And so if you are thinking that one can exclude relapsing SPMS, you're going to end up with a study that has a mixture of patients, and one would have to understand how you would deal with that. And I think it's much more appropriate just to deal with this by a stratification if necessary and or a statistical analysis methods within the studies without excluding those patients. George would take the opinion that it doesn't matter because relapses don't matter in secondary progressive MS from a disability perspective. So either way, one would agree that the language restricting this should potentially be removed from the guidance. We talked a little bit earlier this morning about the pediatric issue, and I've highlighted there the language from the guidance and are difficult. Studies are difficult in pediatrics. This is an understatement, and the generation of specific data is expected. I think we speak from personal and corporate experience that this is extremely difficult to do pediatric studies for the reasons listed here. It's a very limited population. There's no precedent of studies in that population. There's already a resistance to placebo control, even though there's never been a placebo-controlled study in the patients. The other issue is when you're talking about the adolescents, the post-pubertal. So if you take a 13 or 14-year-old who develops their first symptom and then they have to get their second symptom to be diagnosed with MS, and then they have to go on to make a decision to go on to therapy, fail a therapy before they would be willing to consider an experimental therapy, they're already 16, 17 years of age. So it's just logistically, it's very difficult to conceive of that. And in reality, I think, as we talked before, it's possible to model this the data for those patients and extrapolate backwards. So our recommendation would be that be reconsidered within the guidance as to whether this requiring of specific data is expected, and possibly in the setting of using the surrogate as the expected data to cover for the clinical data. I would admit, though, the difficulty of the prepubertal patients is another issue, but I think that that's so exceedingly uncommon as difficult to put into an MS treatment guidance. Other things to consider, not really in the patient population, but other things that have changed, I would say, relate to the measures that we use. And here we're talking about the variation in baseline EDSS, as we've seen in a couple of studies, the OLYMPUS study and the COMBI-RX. I'll come back to this. And the degree of EDSS change that's needed to progress the definition. But also this issue, we've talked about confirmation of relapses is different than it used to be in the early studies. The MRI definitions, I think, are getting pretty much aligned. Most people will agree on the T2 and the T1, but there are variations there, so that has to be taken into account when looking at study data. And then we heard earlier about the brain volume measurement issue. The methods are actually quite good and standardized and precise, but you can't immediately interchange them. I'm just going to deal with the top two there. First one is the EDSS variability at baseline, and this is just something that we as developers should be thinking about when thinking about the disability measures. And this is data from that Peter Chin worked on in another life from the OLYMPUS study, and looking at the variability of the EDSS between the screening visit and the baseline visit, and based on the degree of disability at entry. And for the patients who were not using ambulation aids, you can see that a proportion of those actually had a 1-point progression between the time that they were screened and the time they showed up for the randomization. Other patients had improved by a point. And the point here is that, you know, if 1-point progression movement on the disability scale is relevant, then if they've already moved a point one way or the other before in the 1 month of screening, it tells you that there's some noise in the system, and one needs to consider that when thinking about the analysis for the full study. And the same thing happened in the COMBI-RX. Thankfully, for the progressive patients, many are at the higher end of the scale, and at least there's more consistency there than there is at the lower levels. The other issue here is some data from the FREEDOMS-2 study and the impact of the low EDSS on disability progression. And as the EDSS is low in some of these studies, there's a number of patients who come in with an EDSS of 0. And there's two things from this graph. If we look at the left side, the protocol-defined definition, the 3-month confirmation of the two left bars there, and then the 6-month confirmation. And obviously, just by requiring a longer period of observation or confirmation of disability progression drops the proportions who are progressing. But at the same time, you don't pay much of a penalty because, in fact, the treatment effect is stronger, probably reflecting reduced amount of noise from the shorter period of observation. The other thing, though, comparing from the left set of graphs to the right set of graphs, the definition used on the left was the 1-point change for patients who are at baseline EDSS. The graphs on the right, the 1.5 change when patients come in with the 0, because any clinician who knows going from 0 to 1 is actually very easy. And so putting in that extra half-point step, as was done in the studies of natalizumab and dimethyl fumarate, you can see that the proportion of patients progressing drops by about 10 to 20%, depending on whether you're looking at the 3 or 6 month confirmation. So again, things that we should be thinking about going forward in terms of modifying in the analysis of the endpoint as opposed to the endpoint itself. So in terms of patient population, these are the recommendations. The studies in relapsing remitting MS must be adequately sized with replication, given the to have confidence in the effect size, given the low level of activity that's seen in the present day studies, and particularly so if we're going to be doing comparative studies. Direct comparative studies are needed if information on relative effectiveness is required because the populations have varied, the analysis methods vary. And this is where maybe modeling of patient-level data with adjustments for these various baseline differences could provide additional insights, either in terms of benefit-risk assessment or in terms of virtual placebo groups. And we didn't actually hear about that at all during the discussion today in the placebo group. I thought we might, but whether that's even feasible or not. Early MS patients shouldn't be relegated to potentially less effective therapies a priori. We agree with the guidance on the CIS, just make a recommendation to consider some language on RIS. We disagree with the guidance language about only including non-relapsing SPMS patients in the SPMS studies. We think that should be removed. And then, of course, the language regarding pediatric MS studies should be thought about in terms of whether or not extrapolation into the adolescent group could be appropriate. I'll spend less time on this topic because I think there's less to be said about it. The insufficient treatment response. We've already seen this language several times. And the issue is, how do you define some of these terms about unresponsive or insufficiently responsive? First of all, what duration of treatment is required before you're deemed to be unresponsive? Is it 6 months, 12 months, longer? And does it vary by product? How long to the time to onset maximal benefit of the therapy? So these are almost imponderables and would have to be defined almost product by product. When one thinks about lack of response or treatment failure, what are the clinical criteria? For relapses, is 1 enough? Do you need 2 or more? Do you need more than 2? Or is it just the same as they had before they were on therapy, as is currently one of the labels? Does it depend on how severe the relapses are? Does it depend on whether the relapses are associated with residua after resolution? And then, of course, what's going to be the disability progression requirement in terms of the EDSS? Likewise, for the MRI criteria, it could be counts of GAD lesions, counts of T2 lesions, but how many is actually evidence of a treatment failure? Some say any activity. Others say, no, you need a certain number of them. Some of the labels have the concept of having 9 T2 lesions on a scan. This is actually irrelevant because that has nothing to do with activity. It has everything to do with what's happened before. So the labels themselves are somewhat misleading in terms of what the criteria should be. We already heard also in an earlier presentation also that issues about addressing safety, tolerability, and patient preference are not ever considered when you're thinking about the issue of unresponsiveness. And what ends up is the post facto definitions of populations in some of the SMPC labels based on these criteria that are not necessarily easy to define. So given that there's no consensus on the minimum, and I emphasize here the minimum, nobody could get to an agreement of what's the minimal amount of clinical and MRI activity that would be agreed as demonstrating insufficient treatment response, and given also that the EFPIA does not agree with the staggered approach, there's really no need to have this concept of insufficient treatment response in the guidance, and so we would recommend to remove it. This would also maybe avoid some of the issues of post hoc definitions. Sponsors themselves, as we said, may well target subpopulations due to safety concerns, and the guidance should be obviously open to this, and I think probably is. The last couple of comments on the benefit risk considerations. The statement is my underlining there. The anticipated benefit risk profile should be weighed against the benign or malignant course of disease. Obviously, the problem there is how does one anticipate the benefit risk without making a lot of assumptions? How does one know that a benign patient is going to be benign forever? And by the time they're malignant, then damage has onset. And there were recommendations there about things that could be used for predicting the benefit risk, such as animal data, PD data, et cetera. And just a couple of comments here. That's in general good concepts or good precepts. The issue is that sometimes you can get misled. You know, in the S1P area, we thought S1P3 in the animal was cardiac relevant, but in fact, in man, it's S1P1. So you would have been misled by, or in developing new products, would have been misled in thinking that it would be safe. Pharmacodynamic data may not predict risk. Lymphopenia seen with the S1P receptor modulators can be quite dramatic and is in fact designed that way, does not correlate with safety risks. And many compounds, of course, are first in class, so there's no a priori information about these at the time of their development. And even those that are not first in class have often had modifications that can mitigate the safety issues of the parent. So these are important considerations, but I think that they alone should not define what the subpopulation should be studied, and that the benefit risk profile evolves over time. And I think one of the things we've actually talked about, it's important to consider the loss of, or the reduced benefit of treatment as well as being offset by the safety issues. And I think what I just show here very quickly in my penultimate slide, if you think about patients who are going onto therapy, and this is data from the Fingolimod phase 3 program, and above the line there are all the benefits, if you will, if you treated 1,000 patients with therapy as opposed to not treating them, the number of relapses that would have been avoided, the increase in patients who are relapse-free, the increase of patients who are free of disability progression, and contrast that's the safety cost is below the line in these various safety events. And I think the thing to keep in mind is, so it's hard to know how do you make a mathematical assessment of that, and you make a qualitative judgment. But thinking about them in the way that most of the safety events that occur are in general manageable, they also occur early, whereas the above the line, the benefits generally accrue to the patients while they continue on therapy. And this has been shown by the sustained low activity rates beyond the 2 years of the controlled phase of the clinical trial. So it's not just what's happened within the 1 or 2 years of the clinical trial, but thinking into the future as well. And I would acknowledge, however, that of course that doesn't take into account the rare risks that are of concern to the regulators, the infrequent but serious events that can occur, which may only occur with longer term observation. So from a benefit list recommendation would be including language in the guidance that highlights the impact of reduced efficacy in consideration of a benefit risk. And that gets back again to this issue about informed decision making by patients and their physicians. And consider including language regarding possibly the exploration of structured benefit risk evaluations in helping formulate decisions, although not from an MS development perspective, but possibly from the labeling aspect that you mentioned earlier. So then we're down to one talk.